We're going to give some case presentations based on real patients, and TT is going to just do a little follow-up summary and the role of telemedicine before we finish. So this is, as you can see, Dr. Patrick O'Farrell. He is a Maternal-Fetal Medicine Fellow here in Calgary. He completed his CEGEP diploma in health sciences and then went on to McGill for med school and residency. And he says that's a far reach from humble family farming roots in rural Quebec. So he has developed interest in medical education and utility of simulation and learning. And out of sheer luck and determination, he's also consistently lived where the Canadian epicenter of COVID-19 pandemic happened to be taking place. So I will say, I think Patrick saw every single patient because he was on the hospital at the foothills during the Delta wave when we had very sick pregnant women with COVID. So he is not by purpose a COVID and pregnancy expert. So Patrick, we're just going to do a short snapper, a little case here that might remind you of some of the presentations today, so you can make your diagnosis yourself. And feel free to use the chat to put in guesses. And then our panel, so anybody who is still on the line as prior speakers, you may be asked to guess, or even better if you can just speak up. So yeah, Patrick, fire away.
Thank you so much, Dr. Cooper, and I want to thank everyone for giving me the opportunity to present at today's AFIC conference. I'd like to thank Dr. Cooper and Dr. Obi and Sylvia Vesta for organizing today's conference. It's really great. Without further ado, I'll go ahead with first case of a case presentation, and then Dr. Cooper will present some further cases. So I have nothing to disclose. So the case we'll be discussing is a 35-year-old woman. It's her first pregnancy. Today, she would be at 28 weeks and 2 days, and she recently immigrated to Canada. She herself has a history of endometriosis that was previously managed by laparoscopic resection of pelvic sidewall lesions, as well as a history of polycystic ovary syndrome, for which she had amenorrhea prior to pregnancy. In this context, she was planning to conceive via in vitro fertilization, but miraculously, she conceived spontaneously. So I'll just give you a bit of history of her pregnancy before she came to Canada. So she did have a positive first trimester screen with a nuchal translucency measuring 5.0 millimeters, and this translated to a risk of 1 in 48 for trisomy 21. However, she underwent a chorionic villus sampling, which was negative for trisomy 21, so that was reassuring. And then at the detailed anatomy survey, it showed some of the following images. So maybe you can put in the chat what you think you see. This is sort of a transverse view of the bladder area with some color Doppler on it. And then on the right side, we can see a 2D view of the abdominal area in a transverse view as well. Then if we look higher up into the thorax, you can see in a transverse view that there is more within the thorax than you would expect. So if you guess that the patient has a congenital diaphragmatic hernia, you are correct. So we can see here in a sagittal view, this is looking in the right hemisagittal area. So you can see the right hemidiaphragm along here with the abdominal contents, and here's the thorax. So you can see a little bit of the heart here. And then on the right side, it's the left hemithorax or left hemidiaphragm, where you can see actual intestinal contents going up into the thorax, which is not normal. Importantly, things you want to look at when looking for a CDH is the size of the hernia. So here in this case is measuring about 15 millimeters across. You also want to know what side it's on. So in this case it's on the left side, and you want to know what contents are within the hernia. In this case, we see bowel. So like I had said, location, the size of the defect, what's within the hernia. You also want to note the size and positioning of the heart and the lungs, and we'll go through a little bit of how to measure that. You want to assess the amount of fluid around the baby. Sometimes they can develop polyhydramnios. You want to look for any other associated congenital abnormalities, such as could there be an encephalocele, could there be esophageal atresia, et cetera. Sometimes there are genetic syndromes that can be associated with congenital diaphragmatic hernia, such as trisomy 13. And you want to take a look at what is the prognosis for this fetus using the lung to head ratio. And I believe Dr. Abbasi had described this in detail earlier today. So here you can see on the upper right side, this is a photo or an image of a healthy infant with no congenital diaphragmatic hernia. Here you can see what could be seen in a left-sided CDH, and then this would be a right-sided CDH. So when assessing the prognostication for such a fetus, you want to take a look at the contents of, or the sizing of the lung on the contralateral side from the hernia, and you'll measure what's called a lung to head ratio, where you basically divide the circumference of the lung volume divided by the head circumference, and then you can do what's called an observed over expected lung to head ratio that accommodates for the gestational age of the fetus. And there are different values that can give you an idea of whether there's a good prognosis, worse prognosis, or if intervention, prenatal intervention would be warranted. So in pregnancies that are complicated by CDH, you would want to do serial ultrasound monitoring for the evolution of the CDH, including if there are more contents, if it's getting bigger, if the lungs are getting smaller, and you may consider fetal MRI for more specific information. You'll want to refer these patients to MFM, prenatal genetics, neonatology, and pediatric surgery. If there's a poor prognosis, you consider antenatal therapy with endotracheal occlusion, which Dr. Bassett also mentioned earlier today. And there's a little image guiding, showing you what would happen. So essentially, you would go in a minimally invasive procedure within the airway of the fetus, inflate a balloon so that the balloon will trap fluid within the lungs to help expand it more. If there is maternally significant polyhydramnios, you may need to perform annulus reduction. Other interesting things to do to help would be providing steroids in the event that the patient's at risk for preterm birth. And you would also consider delivering at a tertiary care site. And you'd want to induce in the latter half of a term gestation, so after 39 weeks. So I'm hoping you were able to guess what was the lesion, and I'll let Dr. Cooper go ahead and share some other interesting cases.
Super. And that, we like to have case outcomes, but that patient pregnancy is ongoing. So we can't, maybe next year. Okay, so I am going to, share my screen here. 1 second. And okay. All right, here we go. Again, all of these patients today that you're seeing are my own patients. And so, I've learned from them, and these are patients who have given permission. So I hope as well that you learn, but also recognize that there is a patient behind an image. Okay, so this case is actually from about 7 years ago, but I won't forget her, so I wanted to show this case. G2P1, prior term vaginal delivery, healthy, no medications, non-consanguineous, no family history of congenital anomalies or syndromes, genetic syndromes or stillbirths. The nuchal translucency scan was elevated, and I think somebody mentioned earlier about the fact that we underestimate the nuchal translucency, and this one is underestimated in that they should have brought their caliper down further to the edge of the skin. But it was over 3.5, which is considered abnormal. Screen for trisomy 21 was impacted. It was 1 in 29. She declined genetic screening, and this was a patient who, certainly was, with her religious background, was not somebody who would consider termination of pregnancy for trisomy 21, for example. So that was her rationale. But there are other things to consider, and that's why we do offer genetic counseling. It's not just about aneuploidy. So she had a detailed ultrasound planned and a fetal echo as well, which is part of the recommendations for a nuchal translucency greater than a 3.5. And so I asked the question here, what is the differential diagnosis for an increased nuchal outside of aneuploidy like trisomy 21? And I am happy if some of our panel wants to shout out anything, or you guys please put it in the chat box as to what are some of our risks could be. So give you 3 seconds. 1, 2, 3. Well, actually 5. I'll be generous. 4, 5. Okay. So risks include, as we said, trisomy aneuploidy, so that means an abnormal chromosomal number, trisomy 21, 18, 13, the most common, or monosomy X, which is also known as Turner syndrome. There's lots of other genetic syndromes as well that we might see with an elevated nuchal, or just specific fetal anomalies, structural anomalies, cardiac being a big one, so all of these babies get an echo, but also congenital diaphragmatic hernia, which we just talked about. Okay, here is the next slide. So what is abnormal about these images that were performed at 18 weeks? Okay, I am going to ask someone from the panel who wants to volunteer.
I want to volunteer.
You do? Okay.
I see too much.
Yeah, exactly. See too much. So when I asked one of our residents, our fourth-year residents, to look at this picture and tell me what they thought, she's like, things inside the brain look too wavy. And I'm like, I like that. Things look too wavy. So yeah, we have hypomineralization of the cranium, and we also have an abnormal skull shape. It almost looks lemon shape here. Yeah, so as a result, we see structures that normally would not be seen because of a more mineralized skull. Okay, I was going to bring that in, but here we go. We've got now someone, Lisa, can you describe what you're seeing? Lisa, hi.
Well, it looks like a 4-chamber heart on the left one, and then kind of like an abnormal 3-vessel view on the next one.
Yeah. What else about the chest looks abnormal?
Well, yeah, it looks like the ribs are squishing in.
Yeah, exactly. Yeah, the heart views were suboptimal. So in the end, there wasn't a cardiac, but yeah, for sure, these are, if you thought this was the best cardiac views, they're not. They would be seen as abnormal. Okay, who's out there? Janie. Okay, we don't have Janie. Okay, what's abnormal about these bones? Janie's not answering. Monica, are you there?
They're short and curved.
Yeah, exactly. You can see they're curved, and just eyeballing them, that's not what a humerus should look like at 18 weeks. And same for the femurs. They actually put a question mark femurs. Okay, so if we look at the biometry, we have head circumference that works out to be equivalent to gestational age and by BPD. Abdominal circumference is a little smaller, 16 and 3, but look at the femur length, 13 weeks and 1 days, and humerus, 13 weeks and 1 days. Definitely something is not quite right here, and this is all the long bones were measured, and as you can see, they're uniformly less than the first percentile. So as I said, this patient wasn't someone who would normally terminate a pregnancy. It was against her religious values. She came back at 21 weeks and 5 days. And Dr. Chu, what does this circle where it says with comp mean to you? What's
Compression. Is
These
that
are dramatically shortened bones.
Oh, sorry. I think you're
you have to turn your video on.
It's on.
okay. We'll just pause you. Okay, if you want to just turn off your mic, I think that's the delay. TT, you can pipe in.
Oh no, just exactly what Sherry was saying with compression, just
Yep.
like she said. Yeah.
With compression. So basically, this is just slight pressure with the ultrasound probe caused a deformation of the skull. So What happened next or at the same ultrasound is we talked earlier about hydrops and ascites, and right here, this is not Dr. Chu's pseudoascites, that's actual fluid, and as well as we have a pleural fusion as well. So this was development of hydrops. So we had reduced mineralization of the cranial vault. All long bones were less than the first percentile, which means if you have, if they're uniformly short, it's micromelia, with abnormal angulation, a small thorax with irregular shaped ribs. Okay, I want people now to go to the chat box and to, oh yes, I see Jasmine, got it right, as their guess as to what the diagnosis is. Okay, so findings are consistent with a lethal skeletal dysplasia, and she was induced at 22 weeks and 6 days. And as we suspected from prenatal ultrasound, it was osteogenesis imperfecta type 2. And the findings pretty consistent that, poorly ossified skull, short distorted limbs with multiple fractures, and beaded ribs with multiple fractures. So just as a quick review, there's different types of osteogenesis imperfecta. It's related to collagen disorder. It's known as the brittle bones. You can have a very severe type that is compatible with life, but with severe, long-lasting physical challenges. They're often wheelchair bound. But then you have the type 2. There's two types. This is type A. It's lethal. That means that these babies cannot survive through a pregnancy or only for a very short time after birth, related to the fact that their bones are so fragile and break so easily, and taking a breath theoretically would cause bones to break, but because that happens in utero, the lungs do not grow properly, and as a result they cannot oxygenate outside the womb, and that's due to pulmonary hypoplasia. So the demineralization of the cranium allows compression with pressure from the ultrasound probe. Interesting that this can be diagnosed as early as 13 to 15 weeks. So when we asked earlier about why do you want to put that attention to the early or late first trimester ultrasound, it's because of these reasons. The patient chose to or decided to induce labor because of the development of hydrops at 21 weeks and a half, because of the association, as we knew at this point, very high risk, but also association with Merer syndrome or Ballantyne syndrome, which is where a mother develops preeclampsia when she has a hydropic baby. So how many minutes do I have left? Do I have time for one more case? TT, you get to answer. I'll do one more case. One more case. She's saying no, I'm saying yes. Sorry. And there's osteogenesis imperfecta. That's not, again, this particular patient. Okay, so this is a patient who's very close to my heart, 25-year-old. She had first trimester screening, and we don't have a whole lot of time for questions or to have this interactive, but as you can see, there's something not quite right. If anyone wants to shout out what they think is not quite right about this baby.
The head, maybe?
Yeah, the head, as you can see. So look at this angle. It's like, almost looks like it's a triangle. And you can see again, they cannot clear this up. This is not artifact. And when you get transverse imaging of the head, and I know these are not great pictures in the sense it's just really hard to image, you can see this mass here. So what's this called? When you have, protrusion at the base of the skull of CNS matter. It's an encephalocele. Okay, so we have an encephalocele. These were the kidneys at 12 and 3, and they certainly seemed just not typical, more cystic almost, but when the sonographer was taking pictures. Hands and wrists were also noted to be abnormal. If you can see sort of the angulation of the wrists, they're quite flexed as well with this image. So we have the wrist and the hand and the hand. This is a good catch again from the sonographer. I want you to look at the hands, and these are fingers. So you can count them 1, 2, 3, 4, 5, 6. Okay. And so polydactyly, and it's bilateral. Okay. So again, this is a patient who would not choose pregnancy termination, and she did not choose to have additional investigations. Of note, she and her partner are consanguineous. It means they are related. They were first cousins. And these are the kidneys at 19 weeks. As you can see, they're very abnormal. They're quite large and obviously cystic here. And then again, imaging was definitely suboptimal. As you can see here, this outpouching at the back of the brain demonstrating the skull, the encephalocele. So we have a combination of encephalocele, polycystic dysplastic kidneys, and polydactyly. Can anyone, we got some encephalocele. Does anybody know the name of this syndrome? This is the classic triad of a particular syndrome. I'm gonna sing the Jeopardy song. Yeah. Oh, TT sings better than me. Start singing.
Dun, dun, dun.
No, that's not the Jeopardy song.
I know, I forget it. The minute you ask, I forget.
Okay, Patrick, are you there? You're the fellow. We get to pick on you. No?
Here.
What?
I am
Sorry.
here.
Yeah. Do you know what it is?
I don't know what this triad is. No.
Okay, you are, because we put you on the spot in terms of almost like 1,000 people. You'll never forget it. Okay. Anybody else?
Match.
Okay, so these are the kidneys at 26 weeks. Dr. Chu, tell us what it is.
Is it Meckel-Gruber?
Yes, it is. Good job, Meckel-Gruber. That's why you have your fellowship certification, because yes. So it's a classic triad, though there are other findings. These were the kidneys at 26 weeks. Look how solid they appear, solid sort of microcystic. And then look at the amniotic fluid at the same time, already oligohydramnios. Well, yeah, we don't have a 2x2 pocket. Okay, so at 34 weeks, she had an intrauterine fetal demise, and she had an induction of labor. We said encephalocele, massive bilateral cystic kidneys, polydactyly, Meckel-Gruber. Again, this is not this baby. This particular, but this is what this syndrome is. You can see the encephalocele right here. The abdomen seems more protruding due to the big kidneys. You can see the abnormal flexion of the wrists, and on the toes, at least here for sure, you can really appreciate the polydactyly. There are other anomalies associated with it. Usually it's an autosomal recessive inheritance. And so in her case, they didn't have the exact gene mutation. There's different genes, but they were counseled. There's a 25% recurrence with the same parents. So
Compatible with life?
Yeah, it's incompatible with life. One, because of the lungs, but also with the encephalocele, and the other, so these babies don't survive much after birth. So this lovely couple went on to get pregnant again, and I was their obstetrician again, and unfortunately we saw the exact same thing with the second pregnancy. And that was a really hard pregnancy for her. Because I think the first pregnancy, they sort of said, okay, well, this is God's will, or Allah's will was their sort of philosophy. But with the second pregnancy, it really took them hard. And I was there at their delivery of their baby girl and examining that poor little baby. But there was no suffering. But here's the good news is that following that, I get the next message that they're pregnant again, and everything went absolutely perfect. And I know Michelle is out there. She scanned them a lot in their second pregnancy, and they delivered a term full, happy, chubby, very lovely, thick hair baby boy. And they had the equivalent of Irish twins. So then they just delivered their daughter 9 months after their son. So happiness does follow tragedy and sadness in these families. And that's why we keep doing what we're doing. Okay, so I'm getting kicked off for my third case, but I'm going to just show you a picture. Okay, I'm going to go really quick. Triplets, yay. Monochorionic with thin membranes. These are all pictures by Michelle. Normal nuchals. Yes, we can do aneuploidy. We can get lots of anatomy in the first trimester. Everything went great in the pregnancy until yesterday. And look, isn't that neat? There's our three little first trimester babies, and there they are. 1, 2, 3. They were delivered early because monochorionic twins are at higher risk, let alone triplets. And baby C, who actually looks pretty good there, had growth restriction and abnormal Dopplers. And not only that, look at that. We have a marginal cord insert. This is the first trimester, 12.5 weeks. And we have a velamentous cord insert and a marginal cord insertion. And that's exactly what we saw here. And look at that baby face. And there's like a baby hand. Isn't that the cutest thing ever? And if you go to the Twitter account, you can actually show the video of these lovely babies. Okay, I'm done, TT. I'm done.